Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Good afternoon, everyone. It looks like our host Paula is having a little bit of a audio issue. If you were tuned in yesterday, this was similar to what happened, but today we are prepared. I'll go ahead and give the introduction for today's session, and we'll work behind the scenes to get Paula back online. So hello, everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I am not Paula Robeson, I am Anne Watkins, and I will be your sit-in host for the next 10 minutes or so, or until we can get Paula reconnected. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we are live, I want to remind everyone how to ask questions to the presenters. Since the audience lines are muted, we don't take questions over the line. However, you all have the opportunity to type your questions into the question box at any time. Paula will check for questions at the end of the session. Please don't feel like you need to wait until the end of the session to type your questions in. Just type them in as you think of them. We're delighted today to be joined by colleagues from two member organizations, the Children's Hospital of Eastern Ontario and the BC Children's Hospital, for today's session titled COVID-19 and Kids, What We Know and What We Do Not Know. For those of you on Twitter, please tag us at Child Health Can for any webinar related tweets, and please share away. Today, I'd like to welcome our speakers, Dr. Nicole Lasseau. She is a professor at the University of Ottawa in the Division of Infectious Disease at the Children's Hospital of Eastern Ontario in Ottawa, Ontario. She is a clinician in both adult and pediatric infectious diseases in Ottawa and Kingston, and is the current chair of the Canadian Pediatric Society Infectious Disease and Immunization Committee, and current chair of the Antimicrobial Resistance and Stewardship Group of AMMI Canada, in addition to a medical director of antimicrobial stewardship at CHIO. Dr. Srinivas Murthy is our second presenter today, and he is an investigator with BC Children's Hospital and a clinical associate professor at the Department of Pediatrics, the Faculty of Medicine at the University of British Columbia. He is leading a national study of hospitalized patients with confirmed COVID-19 to determine effective treatment practices. It's my pleasure to pass the virtual podium over to Nicole.
Hello, everyone. Can everybody see my screen?
Yep.
Yeah, great. Okay, so we'll go. So we're expecting both of us to each speak about 20 minutes. So we'll make it 40 minutes and then have lots of time for questions at the end. So the first slide just shows you the WHO map that I downloaded yesterday. And certainly this is a pandemic, because you can see cases in every country of the world. Okay. Okay, so the objectives are really to describe the epidemiology of COVID-19 in children, and then speak a little bit about the transmission dynamics and what we do and don't know about COVID-19, and some of the rationale behind the infection prevention and control issues for COVID-19. Then Dr. Murthy will review the testing methods and describe common and much more rare presentations for COVID-19 infections in children. So just to start off with, as you know, it was named COVID-19. The virus was named COVID-19, but really it's the SARS-CoV coronavirus 2 virus, an RNA virus, and it enters the human body probably through the angiotensin converting enzyme receptors in the lung. That's why it primarily causes pneumonia. And you can see the cartoon of the virus where there's spike proteins, there's all kinds of proteins that are really going to be very important in targeting vaccines in the future. So coronaviruses certainly aren't new to children. You can see that there's commonly circulating coronaviruses that have affected children for many, many years, and we all have them on our panels for respiratory infections. But in the last couple of years, in 2002 and 2003, Canada experienced, as well as other countries in the world, including China, the severe acute respiratory syndrome, which did have some infected children, but certainly not very many, and there was no mortality. Then later on in 2012, we had the MERS-CoV epidemic, which unfortunately did affect some children and caused some mortality. So it was a higher virulence vaccine. And then outlined in the red, obviously, is the current SARS-CoV-2 virus, one of the coronaviruses that we'll go into today. And as you can see, the commonality between all of these is there's certainly bats that have this virus, and then they usually have a second intermediate host. And for the COVID-19, we think it's the pangolin, this sort of scaly looking animal that you see in the picture. So that gives you an overview of the coronaviruses in children. So, you know, it's mainly affected this pandemic adults. However, we do have some information on the proportion of all COVID-19 cases in the world that have been confirmed in children. I've only given you a sample here, but generally speaking, in all the countries, it's been less than 10% of all COVID-19 that have been implicating children. So a small proportion. However, when you look at the numbers, you can see that different countries have screened symptomatic and non-symptomatic patients. And so you'll have a little bit of a higher number there. And you can see, for instance, Italy, where they didn't do any screening or outpatients, but they did mainly hospital-based symptomatic testing. And so that was very small, currently at 1.2%. And again, in China. So we'll look at the Canadian data, and this is current as of May 20th. So you can see, again, children less than or equal to 19 years of age comprise only 5.5% of the cases of confirmed COVID-19 in Canada. Now, as you know, the hospitalization rate is much higher in patients, people that are over 60 years of age. And in terms of children, only 34 or 1% of the total have been 1% of the total cases of coronavirus have been hospitalized, and only 2 so far that we know of, although the reporting may be a little bit delayed, have required ICU care. And so far in Canada, there's no deaths. If we look at the similar situation in the United States, remember, they had difficulties in testing initially, and so there was, of their 149,000 cases that they reported as of April 2nd, only 1.7% of cases were among children less than 18 years of age. And the median age was quite high, 11, and of those, 5.7% were hospitalized. So they're reporting a higher hospitalization rate than in the Canadian cohort. But again, a little bit more of them were greater than 1 year of age. And about a quarter of the pediatric cases where they had information, so remember they only had information on 345 of those 2.5 thousand patients, but of those, there was a quarter of them that had underlying conditions rather than perfectly healthy children. And of note, 91% of them where they had information reported a household contact. So it's an adult household contact, which gives you a flavor of maybe where they would have got it from. So as we all know, the person-to-person spread was identified very early in this epidemic, initially in Wuhan. And I've just put this up to show you how exponentially easy it is to spread this virus. So this is from the Washington area outbreak, and they had 2 symptomatic people that they identified early on that attended church events over 2 days in March, and later tested positive. So these were minimally symptomatic patients. They identified 92 of these of attendees at this particular church, and 35 of them developed COVID-19. So it shows you how even these 2 people that were able to go to these activities caused disease in many people, at least a third of the people they possibly came into contact with. And then of those 35, of the 92, that at least were at the church, there was an additional 26 cases. So you can see the exponential growth of the epidemic just with basically casual contact. So as we know, the spread of the virus is really person to person through respiratory droplets. And these are typically expelled when a person coughs or sneezes. And usually, but we can expel some kind of fluid when people are laughing, talking, depending on how close you are to a patient. These droplets that are actually fluid filled usually fall within a few meters. Most of them fall within 2 meters, but it would depend on the force of a cough. For instance, a 1-year-old probably is not able to cough and expel the cough droplets more than a meter possibly, or even less, whereas a teenager who has a very forceful cough can probably expel at least 2 meters. But the point is that these droplets can not only fall onto our hands or on other people's faces, but they can also contaminate surfaces. And just to be clear that so far, even though some of the aerosols can be very tiny droplets that can potentially be suspended in the air and linger for up to 3 hours if you use a machine to produce these. It hasn't really been proven yet that COVID could be translated by inhalation of the aerosols. So I really want to make that point because people often get very anxious about the air around them, but most of it so far hasn't been proven to be by inhalation. So the big bugbear in this pandemic is the pre-symptomatic spread, and that really wasn't very obvious at the very beginning of the pandemic. But now we have multiple levels of evidence that show us that pre-symptomatic or asymptomatic spread is likely very much more common than we think. So first of all, there's many case series that have looked at family clusters in China and coworkers that were completely asymptomatic or minimally symptomatic, I would say, and spread the disease to other folks. And then there was a very interesting cohort in Singapore where they actually, in Singapore, they have a very good healthcare system and public health, and they actually did extreme contact tracing on 242 positive individuals. And there was a choir group of which everybody was asymptomatic, and people didn't even develop symptoms, minimal symptoms, until 2 or 3 days after they went to the choir practice. And yet, many members of this choir developed COVID without any other contacts. So they left their home and they had just gone to this one choir practice, suggesting again that there was asymptomatic spread. And then in the US, it was stunning that even in the long-term care facility where they did extensive testing, 56% of patients that actually were tested were essentially asymptomatic, and the many people were affected in this long-term care facility, suggesting that, again, that through contact tracing, many cases were probably transmitted this way. And then if we look at the virologic evidence that is now accumulating that in patients who are serially followed, so if you're a contact of a case, serially follow the viral loads in people and by doing daily or aspirates, and you can see very clearly that the viral load in asymptomatic or even minimally symptomatic people is very similar to symptomatic people. So telling us again that even somebody who doesn't exhibit any symptoms, they could have virus and they could potentially spread this. But I think the strongest evidence really is the modeling evidence that has shown us from many countries now that if somebody is a contact of an asymptomatic person, and we expect the incubation period to be 5 days, but if you get symptoms basically 3 days after you've been in contact with a person that's been diagnosed, we sort of think, they must have been infected before that index case was actually positive. So it's actually interesting that up to 50% of cases now are felt to be transmitted from people who are asymptomatic. So 30 to 50, and I think that's the reason why we're having trouble really controlling this outbreak just by doing contact tracing, and we certainly couldn't be just putting people who are symptomatic in isolation. And if we look at the pediatric data, the initial pass with the Dong paper in Pediatrics, their cohort, of their large cohort, indicated that 4.4% of the children that were confirmed were asymptomatic. But the one in Wuhan, where they actually did a little bit more digging with these cases, determined that up to 16%, so 15.8%, were actually asymptomatic. So it shows you that the children also can be asymptomatic. So this brings us to the point of the schools and whether children are actually super spreaders, even if they're asymptomatic. So it's a big deal in children, obviously, because it affects, you can see there, up to 900 million children have been deprived of school since March 18th. And the reason schools were closed was part of a package deal of shutting everything down, but really because the influenza outbreaks are known to be, every year, the epicenters are in children. And it's usually children that bring this home to the adult family members, parents, grandparents, and cause infections. In contrast, though, so far COVID-19 has been, as I've shown you, much less common even in asymptomatic children or even in symptomatic children compared to adults. And when they've looked at families with children, it's really, in China, there was a large study of households, and only 7% of the children in households with infected adults actually eventually became infected. So not all children, it's not a 100%, it's a very minority of children, for some reason, we don't know why, have become infected even when they have COVID in the household. And then another way to look at it is only 10% of family clusters that have been investigated in Singapore and Japan have had children as index cases. In Australia, where they didn't close some of the schools, there was very little transmission from infected children to staff. There was one that they've published that there was 8 infected staff and 8 infected children, and of over 700 people, there was no one that subsequently became infected, children or staff. And then obviously schools were closed very early, but so far, where there have been reopening of schools, there hasn't been a school outbreak reported. So I think it's things to consider when we talk about, the school boards talk about reopening and the provinces talk about reopening, because there are unintended consequences to school closure on the mental health and social inequality that's brought about with school closures. So one of the other important points, as I alluded to before, is the stability of SARS-CoV-2. So as you know, cardboard, and you can see that in the third box, cardboard, it only lasts probably 4 to 8 hours, only because cardboard absorbs that fluid, and obviously the virus is less viable once it's dried. in contrast to steel or plastic, where the fluid wouldn't be absorbed, and so the virus probably lasts like a day or 2 days, or even 2 to 3 days on these very hard surfaces. Which brings me to this point about the infection prevention and control. So we all know that we use personal protective equipment to protect our skin, mucous membranes, and our clothing from being contaminated with these droplets. But one of the important things to remember is that surfaces really need to be cleaned, especially in offices when people reopen, because these are the things that can persist and can transmit infection as well. So this is called an indirect transmission. So the next, this slide really emphasizes the reason why we have the 2 meters is because of the 2 meter distance where the usual persons with the adults with tussive force can transmit their droplets 2 meters. And then wearing masks when physical distancing is not possible, because these people may be asymptomatic or pre-symptomatic individuals with COVID, and they could put their virus either close to you so that you get it on your hands or on the indirect surfaces. And masking isn't a new thing. In the influenza pandemic, the public was also asked to mask for the duration of the epidemic. So it's a very good public health measure, actually. So my last slide is going to be about vertical transmission, and there's been lots of angst, obviously, about this, and it certainly is very important. But so far, respiratory viruses have not been proven to cause vertical transmission from mother to infant, in distinct contradistinction to HIV, hepatitis B, and very occasionally hepatitis C. So there was a nice review that you can look at, but that was published April 2nd. Subsequent to that, there's been some case reports in the JAMA, but really the serology was not consistent, and I urge you to go read the editorial by David Kimberlin, which really looks at the pattern of the IgM response, which was probably a non-specific response. So definitely not proving congenital infection. There was a 28-week-old infant that had a PCR positive day 7, but postnatal transmission is much, much more common if a mother and a father or other adults in the household, grandparents, are infected. And then there was a latest article on May 14th in CMAJ. The PCR test at birth, however, was one of 3 targets, so really was not conclusive as to whether vertical transmission takes place. So I think that's one of the unknowns, but so far there is no proven vertical transmission from mother to baby, but there certainly can be postnatal transmission. And I think with that, I'll send it over to my colleague, Dr. Murthy.
Thank you so much, Nicole. Just before we pass it over to Dr. Murthy, we'll get the screen sharing headed his way. This is just my chance to remind the audience to type in your questions as you think of them. I see a couple coming in, and we'll hold those to the end. And this is also my chance to check in on our host, Paula, to see if her audio has been reconnected.
I'm now on the phone. Is it working?
Yes, it is. Great. So Paula will take over from here, but before she comes in for the Q&A, we'll pass it over to Srinivas in BC.
Hello. So I'll just follow through with some of the clinical disease and differences between kids. This is a nice figure that came out a couple of weeks ago from a paper looking at sort of the trajectory of most patients, knowing that there is a spectrum of disease, obviously, as Dr. Lasso described earlier, in terms of symptomatic versus asymptomatic, where the early phase being the viral response phase with sort of the mild constitutional symptoms, and then leading to the more severe illness, which people are seeing in hospitals with shortness of breath, hypoxia, and subsequent organ dysfunction. Diagnosis, I think, is fairly clear from most of the people on this call. Many people on this call probably have had this swab done as part of their symptoms during this outbreak. So a nasopharyngeal or an oropharyngeal swab, passed and getting samples from the back of the nasopharynx. One note is that there's a large amount of variation in the quality on the types of tests that are being performed across the world. The level of detection ranges anywhere between 100 to 6,000 copies per milliliter detected. True sensitivity and specificity of these tests are really unknown. This is a long list of all of the FDA-approved PCR tests that are in use in the United States right now. And you see sort of the difference in terms of the sensitivity, specificity, and the positive and negative predictive values, as well as the level of detections. Of note, the trial data, that column, you have to look at the specifics. Trial data is very sparse for all of these different products. And so typically with one of these tests, they would go through some research to make sure it's validated, but this time that has not been done. We think that most of these tests are fairly good, but obviously we don't definitively know. The next way of diagnosing is serology, but serology for acute disease is not particularly helpful. As you can see, IgM develops as over the first few days and weeks of illness, and then subsequently followed by an IgG response over the subsequent weeks. And the IgG typically is in the convalescent, and that's what we'll look for both with IgM and the serologic tests. There are a number of serologic tests that are available, mostly in the United States. There are a larger number of diverse serologic tests with a varying array of quality and a varying array of sensitivities and specificities. In Canada, many tests are being scaled out, some for research and some for clinical purposes. And this field is rapidly moving in terms of the best tests for this purpose. I did rapid testing for PCR on this because that is also a moving space with one recently being recalled for some quality control issues. Who gets tested? I'm not going to get into the specifics of that. That is varying across Canada, and each jurisdiction and each province has their own policy, particularly in children. And so that's not something that we can talk about right now in a matter of minutes. Disease. And so in adults, we're seeing lots of patients, obviously, around the world. This is a global data set of tens of thousands of patients looking at the difference between males and females, showing that a male predominance and the elderly predominance of all hospitalized patients with disease. You see at the very bottom of that left side of your figure that the numbers of children that are hospitalized compared to the numbers of adults are much, much smaller, as you can imagine. And remember, this is tens of thousands of patients across the world. In adults, a majority of the patients have or hospitalized patients have some comorbidity, hypertension, chronic cardiac disease, and diabetes being the three leading comorbidities that are associated with hospitalization. In kids, this is again a large data set of thousands of patients. So you can see across ages here, if you look closely at the less than 10 compared to the older patients, that, for example, there may not be that many differences in some major lab findings, such as white counts, neutrophils, prothrombin time, and CRPs, and so on. And so it's fairly consistent with the older populations, acknowledging that there's a much smaller sample size. If you look at hospital length of hospital stay, the children tend to have a much shorter length of hospital stay, and so this is a violin chart. And so the longer and skinnier each figure is suggests a longer hospitalization. And so most children, 0 to 9, tend to stay only a few days in hospital of the children that are hospitalized around the world. And so this is, once again, thousands of patients around the world. In the United States, same features. And so Dr. Lasso mentioned some of this data earlier. So the median age is 11 of all the children being diagnosed. Most of them had fever, but less so than in the adult population. Most of them had cough, but less so than in the adult population. And only a small proportion were hospitalized, and an even smaller proportion were admitted to intensive care, with a quarter of them having an underlying condition, mostly asthma. We keep real-time tracking of many of these circumstances in the United States in terms of the numbers of admitted children to hospitals and intensive care units. And so this is data from yesterday, showing that there were 28 confirmed deaths across the United States in all pediatric intensive care units, or at least 183 pediatric intensive care units, and 471 were positive. Of note, this includes people above the age of 18, or about a quarter of them are above the age of 18, because many pediatric hospitals and pediatric intensive care units in the United States have been converted to adult intensive care units for a short period of time. And so you see in the top left age distribution, the patients above 18 and above 30 represent about a quarter of all of these 471 patients that have been admitted to pediatric ICUs across North America. Many ICUs in Canada are contributing to this data set as well, but acknowledge that there's only 2 to 3 intensive care admissions across our country thus far. If you look at sort of specific data as to children with coronavirus admitted to US and Canadian PICUs, this is data from JAMA from a couple of days ago, showing that the critical severity of illness was about a third of all patients admitted to pediatric intensive care units. 1 child needed ECMO, if you look down near the bottom, and look down at the outcomes, 65% of them were discharged. 2 deaths occurred in this cohort, and this is, I think, across 60 or 70 pediatric intensive care units. And the median duration of stay is about 7 days total. A quarter of these children required some vasoactive support, and 38% of them required intubation. Why? So that's a sort of $1 million question as to why children tend to be less affected severely than adults. And this is out of keeping with other respiratory viruses like influenza and other things that Dr. Lissow mentioned. And there's a number of theories sort of floating around as to why that is. One of the possibilities is this angiotensin converting enzyme, which seems to be the receptor for the SARS-CoV-2 virus in the respiratory epithelium. And so this is a paper that came out in JAMA yesterday, looking at age-based gene expression of angiotensin converting enzyme in children compared to adults, showing that it increases with age. Whether this is a driver of why children are less affected and have less severe disease than adults is unclear, but there does seem to be differential age-based expression of this ACE2 receptor in children compared to adults. Note that the y-axis is a log scale and it's a truncated log scale, so those differences may not be that profound, but it's still something to keep in mind as to a possibility. The other leading contender, I'm not going to go into the specifics of this. This is a preprint that came out a couple of days ago about the serologic differences between adults and kids. And so either it's a receptor-based issue or an immune-based issue as to why children are less affected. And this is looking at coronaviruses in general and looking at the different immune responses in children compared to adults, given the numbers of coronaviruses that many children are exposed to compared to adults. Once again, we don't have time to go into all of the specifics of this slide, but just to say that there's lots of work looking at the immune system and the immune response in children and the numbers of viruses they're exposed to and whether that cross-reactivity to other coronavirus exposures affects their ability to react to this current circulating coronavirus. What's in the news right now a lot is these other atypical manifestations of COVID-19. First, sort of the skin manifestations, and many people on this call may have seen sort of the COVID toes that have been described, which is sort of a burning toe type feature which disappears after 7 to 20 days. Histologically, it's unclear as to why this is. There's a lot of evidence in the adult population about an endothelial dysfunction and a prothrombotic state. And so this could be a manifestation of that or just generalized hyperinflammation. Similarly, there's a diffuse erythematous macular rash that's been described in Italy at the onset of disease, but no real correlation with severity. And as well as stroke. There's been a number of young adolescent type reports of people with atypical stroke with positive COVID-19, reflecting sort of the endothelial dysfunction that goes with COVID-19 infection. But sort of more timely is this hyperinflammatory shock with features of Kawasaki disease syndrome that's popping up more and more across the world, with a few cases in Canada thus far. And so there's been lots of news reports as well as different case definitions that have emerged as to what this syndrome is, and lots of science emerging as to whether or not it's related to COVID-19 and what the best treatment and diagnostic strategies would be. So the WHO has put out a case report, a case definition, which consists of the following. If you are a child and have 2 of the following symptoms, namely a rash, conjunctivitis or mucocutaneous inflammation signs, hypotension or shock, cardiac abnormalities, coagulopathy, or GI symptoms, and inflammation, and an evidence of COVID-19 infection or contact with patients with COVID-19. So that's deliberately broad, so that at a time of circulating COVID-19, it's impossible to rule out. And so you can say if the child has those clinical features, they would meet this case definition. I believe the Canadian Pediatrics Society is coming out with a definition sometime in the next day or so, which would sort of mimic this. The CDC and the Europeans have also come out with similar definitions. So in Canada, there have been cases across the country, isolated and sparse, but still occurring. In the United States and in Europe, those cases are far more frequent, probably lending some credence that this is COVID-19 related. The exact nature of that relationship is still ill-defined. On the left is a figure of Kawasaki disease incidence in Italy compared to 2019 and 2018, showing that there is a huge spike in Kawasaki disease over the course of these preceding past few months, suggesting maybe some temporal relationship with the COVID-19 outbreak. And in terms of the actual clinical symptomology, this is what people are seeing with the conjunctivitis, which seems to be very notable and very consistent across all of these reports. Red and crackled lips, which sort of is keeping with the Kawasaki disease type syndrome, the lymphadenopathy, the rash, the fever. They'd say that's greater than 4 days in this, but the WHO says greater than 3 days. The CDC says greater than 1 day. And the cardiac abnormalities, which are notable, given that the number of children with coronary artery abnormalities are significant, and this deserves sort of attention by people who may manage these children urgently. Diagnosis and management is relatively supportive for now, with every institution and region having their own specific recommendations. It's important, and this is a plug for the Canadian Pediatric Surveillance Program, and as well the WHO has its own data platform for data entry, so that we can learn as much as possible about how many cases there are out there and what those cases look like, and whether or not we're learning anything new about some regional variation in Canada or other parts of the world. There are a number of sort of institution-based guidelines that exist. This is on the left is Evelina in London. On the right is a New York University hospital, which have come out with sort of management strategies, not necessarily guidelines about best things to do. None of these are necessarily evidence-based, given its overlap with Kawasaki syndrome. The recommendation is in most cases for IVIG of some sort, but this needs to be sort of a multidisciplinary conversation with each patient with the local expertise that's available. I know that most children's hospitals across are scaling up their sort of algorithm to figure out what the best way of managing these children would be. So summary, I think that's 40 minutes now, perfect. So children comprise a very low proportion of cases in all countries. They do not appear to be index cases in clusters, though there is virus present in respiratory secretions. Testing is crucially important, as many of us know. We still don't know the role of serology in the management or the diagnostic strategy in this. Children usually have mild or moderate clinical infections with COVID-19, but may have a robust inflammatory response, which is this Kawasaki disease-like syndrome, with significant morbidity or even mortality. There have been a number of deaths reported in New York and other places in the United States. Vertical transmission seems to be not a major contributor, and it's important to work on sort of public health level interventions and the impact that they may have on children in general, school closures most notably. So that's all the formal slides we have, and I'm sure there are questions that can come up and we can chat about. Back to you, Paula.
Thank you both. I'm just confirming that you can hear me.
Yes.
Perfect. Thank you both, Srinivas and Nicole, for a great presentation. There's a number of questions coming from our audience that I'll share with you now, and I'll encourage the rest of the audience to type any last-minute questions into the question box, and I'll go through them right now. So one, is there any evidence that children with anaphylaxis allergies are more susceptible to acquiring COVID or having a worse prognosis?
Dr. Lucille, I'll give that to you.
Okay, I haven't read anything about that. The biologic plausibility of this, I think it would be biologically not sort of an issue. but it certainly hasn't come up in any of the literature that I've read.
Wonderful, thank you. What are your thoughts regarding the need for physical distancing with not requiring physical distancing with primary age children?
So you mean children like under 5 attending daycare or childcare?
Daycare. I am assuming, based on what's written, it's daycare and elementary school.
Well, for sure, it's really difficult to physical distance when children are playing together, et cetera. So it's an issue of mitigating risk, I think. So if the incidence of disease is low and the morbidity with acquiring disease is low in that particular population, aside from the Kawasaki's, which is giving people a lot of angst, then I think you have to balance the fact that what are we going to do? Put them in a box, or prevent them from playing with their with the other children? I think there's certain times of the day when you can physically distance individuals, such as at when they're eating their lunch. And when they're outside, they can maybe physically distance, and when they're in a classroom setting. But certainly preschool children, it's really difficult in a daycare. So in those situations, I think it's really a matter of risk versus benefit of them attending a childcare, and also controlling the number of children. So if you decrease the number of children in a group, obviously your potential to get transmission is also less.
And building on that, in cases where physical distancing isn't possible for adults, such as caregivers and daycares, and for children, what are the best ways to protect the adults and the children? Clearly, washing hands and cleaning surfaces, but are there other recommendations?
Well, certainly masking of people who care for children is an issue. I mean, we wear a mask, a non-medical mask. The reason for wearing non-medical masks, if we can't physically distance, is in case people do have virus in their respiratory tract, and it prevents at least some of the virus from being spread around on fomites or toys or to other children. So that would be the only other method we would have. But I think that cleaning is probably an underappreciated way of mitigating risk. And then you have to worry about masking for children. I mean, many of these individuals will be toddlers, and whether that's an issue for people is I haven't read a lot of the psychological issues about that, but you only have 3 ways. You either have physical distancing, you obviously cleaning and masking, and then obviously complete no contact. So those are the only ways you can do it. So it's really a matter of risk mitigation.
Great, thanks. Let's see, I'm just looking here now. About neonates, do we have data or about transmission from asymptomatic shedding in the stool of the mother to the neonate during delivery? Is part A of the question. And part B is, do we have NICU experience of outbreaks, and thinking about the neonates on CPAP and healthcare workers in contact with them?
Do you want to get that, Srin?
Sure. And so the evidence of stool-based transmission is still lacking. There has been virus detected, or PCR detection, from stool specimens in patients with disease, but it does not necessarily reflect the fact that whether or not they actually get transmissible virus from there. And so there has not been a report of a virally acquired infection from stool specifically that I've seen or has been reported. First. Second, I guess, is NICU-related infections. There has not been, at least in the United States or Canada, any neonatal ICU-type transmission of disease. That being said, ICU across the country, I believe, has their own protocols for exposed infants and CPAP and high flow and other types of issues.
Great. What advice or recommendations might you have for policymakers with regard to improving data collection in Canada, so we can learn more about the impact on kids?
I think this is very, very fundamental. I think so far we have the Canadian Pediatrics Society that has a CPS surveillance system. There's an ongoing study from what's called PICNIC, the pediatric sites in Canada, entering patients into sort of a database, a study surveillance, but this doesn't include any children who are being seen at non-pediatric hospitals. So that's a gap really in our ability to get all the information we can from these children. And then there's obviously the in-hospital patients or patients that need medical care that I'll let Shrin have a go at.
Yeah, no, it's a very important topic. And I think data sharing across provinces in Canada has always been sort of a challenge given the 10 or 13 health systems that exist. I think this can be an opportunity as we realize the importance of connected hospitals, at least in pediatrics, but even in adults as well, to see that we can track these things systematically and in real time, which is absolutely crucial from a capacity and policy development perspective.
Great, thank you. Question about PCR testing. Can you comment on the sensitivity of asymptomatic neonates in contact of a COVID-19 mom?
I can take that question. Certainly the issue of if you have a confirmed mother with COVID and you're there is a potential of postnatal transmission, and really the question on everybody's mind is there vertical transmission? So the problem is that we have PCR detection. PCR can be found, as we know, not necessarily viable virus, but in the stool of the mother, and there's certainly the mother has got respiratory secretions that likely has COVID. So that baby at birth can certainly be colonized with, can have contamination if the mother coughs on the baby, or even if there's some maternal secretion that has virus particles or virus DNA on that baby. So if that, we don't know when the right time is to take the neonatal swab. So far there's been a lot of latitude given, take it within the first 24 hours. And the main reason for that is really when to take off the precautions, the contact precautions for that baby, the droplet contact precautions. So if that swab is done maybe early on, there is potentially a higher likelihood of having a false positive swab. So some physicians might advocate for taking that swab later on in the 24-hour period, and then you get the result back the next day. So they're basically in droplet contact precautions 48 hours. But most times we probably need 2 swabs to confirm the negativity. All of this is basically based on plausibility. None of it's based really on a lot of testing to determine the positive and negative predictive value of a swab done at 2 hours versus a swab done at 24 hours.
And do you keep the babe in isolation until you get those double negative tests?
So I think it's really important to follow the provincial guidelines in different provinces because and even locally, people have different thresholds really for risk. I would say that in our hospital, we're pretty confident that 2 negative swabs done 48 hours apart is good to remove precautions, but this, people's tolerance for risk is different. So some hospitals prefer, because they're technically a contact with somebody with COVID, they would keep them in isolation for 14 days. So I think the best way to answer that question is really to talk to your local IPAC people, which who usually refer to the provincial guidelines for those kinds of things. One of the things I would say, though, that COVID positive parent or a healthcare provider will certainly not be allowed to visit a child in the neonatal intensive care unit until they're proven negative, yes.
Fair. Has remdesivir been used in children, and has it been found to be efficacious?
I can take that. And so there is a compassionate use protocol in children. There hasn't been a randomized trial performed in children with remdesivir. And so we do not know if it's effective or not, or safe or not in kids as of this point.
Okay. We're living in a world of a lot of interesting questions, but unknowns.
Yes.
What about adults offering personal care to children? And I think this relates again to the school, daycare. Is there data to support the use of PPE among those educators and childcare providers?
Well, that's an important, difficult question to answer. And that, if we go back to the basics, that is droplet contact, and the likelihood is it would be an adult that would be transmitting disease to the child, right? So we wear non-medical masks not to protect ourselves, but to prevent respiratory droplets from landing on a child or landing on their desk, etc. So I think, again, the different school boards across the country, when they open, will have different policies in place to address those questions. And again, it's a question of mitigation of anxiety and also age group. So it's really going to depend on the school board's policies, and some school boards I know in Quebec have sort of left it up to the individual teachers, and some school boards have provided masks for the adult teachers that are teaching the children.
Okay.
And it really, sorry, if I can just add the glove issue. So the gloves is really not really meant for prolonged use. It's a one-off use when people are examining patients. So my recommendation would certainly be no gloves, just frequent hand hygiene.
Great, thank you. Is there any data that identifies increased risk for children with chronic medical conditions like type 1 diabetes or complex medical needs, such as those who are requiring home care and aerosol generating procedures, et cetera, at home?
You see in the American data that the numbers of hospitalized children, the proportions having a comorbidity, either a chronic condition that requires home care or asthma, is higher than the non-comorbid children. Given the numbers of deaths are so small, we can't definitively say that that's a true risk factor, but it appears that their risk for hospitalization if they have infection is marginally higher.
Another comment. One of the slides mentioned that a lot of children had household contact with family members. Was there any data around contact with teachers, daycares, other contacts outside of the family?
No, so those are really just one-off questions from the American data, and the schools closed very, very quickly. So all we are going to get really is the school reopening data that we already have from Australia, Taiwan, but remember Taiwan even didn't close schools in the entire country. Local schools closed, and they seem to actually do just as well and decreasing their caseload without putting a blanket school closure. So I think those kinds of questions will likely be better answered as we move forward in reopening schools, but because we don't have really the data, because schools were closed very, very quickly after the announcement of the pandemic on March 11th.
Right. Does the data provide any guidance around reopening things like outdoor play centers, indoor play centers, other places that attract children in groups?
Well, yes, that's a big question, and I think for the physical and psychological health of children, this is extremely important, and also parents. And so we have to get back to the basics. So outdoor play structures, I think, would be less of an issue, only because if there was virus on these plastic or hard surfaces, potentially wind, dryness, sun would decrease the infectivity of these droplets should they land on the play structures. However, one doesn't know the time period between the child who might have, or the adult who might have put respiratory droplets on an outdoor play structure and the time the next child gets to touch that area and then potentially puts it in their mouth. So I think the outdoor play structures would be less of a risk. However, the indoor play structures, potentially we could clean them, although you probably have to clean them quite often. So I'm not really sure what public health will do with that kind of question, but it's an extremely important question to get back to a normal child life or semi-normal child life.
Right. Is the data on child-to-child transmission biased because children from two different households are now not really interacting together that much because schools were closed quickly and for other reasons? But does the data appear biased in that regard?
Well, certainly now, if people are actually staying just with their own nuclear family, I think the data as to how two families, if they're interacting, will certainly, if there is transmission, then we'll certainly see an uptick in pediatric cases in the next few weeks as we let these families congregate a little bit more. But we'll see, because we don't know this question yet, the answer to this question yet, unfortunately.
Yeah. No, that seems to be the state we're in. The last question I have right now, unless others type in the last couple of minutes, is with regard to school opening, is it actually safe to send children back to school? A nice one on your way out.
Shrin, do you want to get that one?
No, you got that one.
Okay. Well, I think
nobody wants to touch it.
Yeah, the safety really depends on our own personal level of risk that we want to take. So if your child is healthy and you value, it's a sense of value. If you value the social, the educational opportunities that school would offer, and your philosophy is that, well, if they get it, they won't be hopefully severely ill, then for that person, school might be a very good option. The other value you may assess is, I don't want to take any risk of getting any kind of infection, especially COVID. And in that sense, your value judgment on going back to school would be a personal one, to say that I can't take this risk right now. I feel too unsure. And if a child sort of has asthma or has some underlying immunocompromising condition, one may say, I can't take that risk. So I think it really depends on an individual parent values system.
Fair.
And both are valid.
Yeah, and there's probably someone working on similar decision aids around value-based decision aids with regard to the data as well. Mm-hmm. Hopefully. Well, that's the last of the questions. I want to thank you, Nicole and Srinivas, for a great presentation. As we could tell from the many questions, there was a lot of interest in the topic. And typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. However, during this COVID pandemic, we're offering special editions of some of our knowledge sharing opportunities, and these may fall outside of our typical webinar slot. To stay up to date on all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you have not already done so. It's always great if you can watch live, as your questions and comments enrich the discussion. But if you can't, The recordings of these sessions are made available after the fact on our Knowledge Exchange network. For next week, we're in the midst of finalizing the schedule for 2 webinars, and we'll confirm the dates and times shortly. These webinars are Pediatric Inflammatory Multisystem Syndrome and COVID, what Canadian healthcare providers need to know, and we're hosting this webinar in partnership with the Canadian Pediatrics Society. As well, we're scheduling best practices in family engagement and partnership with our colleagues from Holland Bloorview. So thanks again for joining us today. Thanks to Children's Healthcare Canada members, CHEO and BC Children's Hospital, and to our speakers for supporting our webinar program. Hopefully we'll see many of you back here next week. Bye, everyone.